Thank you very much, and sorry I have jumped the queue because I have to leave early, so I don't want to miss my flight. So, changing landscape of intermediate stage HCC treatment, why I selected this topic, because this is the group which is most mismanaged group in our country actually, because we don't know what exactly we can offer. And the new things are coming in to treat, because this is the group which has a very good liver functions, but the tumor burden is high. So we have to come up with solutions for these patients, because we can pull down these patients for a longer survival, or we can do liver transplant in such cases after downstaging. So the event is sponsored by Frozen's, and objectives are that everything is not fit for this patient, but we should go for a personalized multidisciplinary strategy for stage B tumors. And the other thing is understanding of role of TARE in stage B. Introduction, you all know it's a well-known, prevalent in HCC in our country. And BCLC staging, I will just say a few words about the stage B. Stage B is a multinodular HCC with preserved liver functions and good performance status. We can do transplant only under extended criteria, and the other option is the TACE, which is very much used in this group. And for the diffuse disease, sometimes we go for the systemic therapy. But with the recent BCLC guideline, the radioembolization has come in, and it has rolled from the early to the intermediate and even advanced stage, actually. These are various guidelines: BCLC, EASL, American, European, and Chinese. BCLC-B has TACE, radioembolization, OLT after downsizing. These are the various combination of treatments they offer in different guidelines. So what is stage B actually? So it is very heterogeneous phase of liver cancer characterized by multiple liver confined to multiple HCCs confined to liver without vascular invasion or metastatic disease. In 2025, the treatment option is shifting towards these, not from the like standard one-size-fits-for-all approach. It's highly personalized and multimodal strategy. So TACE is still the main thing for this, you can say, stage of tumor. We normally do in 50 to 60% of cases TACE, but there are combinations like immunotherapy, TACE versus immunotherapy, and new things are coming in like radioembolization alone or radioembolization with systemic treatments. Prognosis in these patients is usually mean survival rate, if we treat, is 19 months to 26 months. It depends on the tumor burden actually and the liver functions. And some patients can live even up to 2 years. If we don't treat, the median survival rate is 10 to 16 months. So these are a few studies where we can see the transarterial chemoembolization response. It is, if you look at this bottom, this study, the complete response is 23%, 22% here, and the partial is 32%. So it's the response rate of like TACE in this group is around about 50, complete and partial both actually. The next study is another where exactly the similar thing. It's the partial response is 53% and complete response is 14%. Again, these things depends on what exactly the size of tumor and what exactly the background liver is. This another study has similar results of like 50% is the objective response rate that includes complete response and partial response. So this is our own data. We have reviewed 236 patients, and the modified RACIS criteria was used to look at the response rate. If you look at again, these things reflect in a similar way as in the international, you can say, literature. Always the child A, 67% response is the response rate, and child B, it's a 33%. Same as the story here, complete response, partial response, and stable disease and progressive disease. Similarly, as the tumor size increases, the response comes down actually. So in tumors less than 6 centimeter, the response is really good, both partial and complete. This is another with AFP level, if you compare less than 1,000, the response is really good, around 50%, and more than 1,000, the response is low. Similarly, the child score, child A has a good response, child B has relatively lesser response. And with portal vein invasion, again, if the portal vein invasion is there, the response is less as compared to the absent, like the angio invasion. Radioembolization is the new thing. It's not new thing, it's there, but now it's in the guideline. And we should look at into the option of radioembolization, what exactly we can offer. So it is can be used in early stage tumor. So actually why I'm talking about this, because we received the patient with massive disease actually for radioembolization. Those are referred. We can offer this radioembolization even in early stage tumor, and we can either get the complete response or very good partial response even in big tumor. So it's less than 8 centimeter tumors, the response is really good. And it can be an like curative. We do radiation lobectomy, and sometimes we use this for the hypertrophy of the other side, and we can do resection in such cases. So it is an alternative to TACE, and the survival is always better in radioembolization. What exactly we do after imaging like CT or MRI, we know the anatomy is favorable, especially the arterial supply is very, very important in such cases. We do arterial mapping. We do embolize non-targeted vessels. We give technetium, MAA, this is lung shunt. We do the SPECT and see what exactly the lung shunt is, because the lung shunt is a limiting factor, because if it's a more than 20%, we can't do radioembolization because that can cause the fibrosis in lungs. So lung shunt fraction we calculate, then we measure the dose. That's very important and very critical, how much dose we are going to give. We order the dose, we wait for like a week, we inject the dose, and we do PET CT in 24 hours. This PET CT is to see the distribution of the theraspheres or the radioembolization material. So the things has changed as the TARE has started. Previously, the standard dosimetry was used. In this case, we were injecting like 120 gray of radioembolization material or theraspheres non-selectively into the tumor. Because here, the dose is low, the idea was to save the liver functions. But the disadvantage was because this can't burn the tumor very well. So the personalized dosimetry came in. Personalized dosimetry is actually, you can say in a simple words, we do super selective or selective TARE. We save the normal liver, and we give maximum dose to the tumor or tumor-related liver actually. So the target is to give 200 plus gray of the dose, but we can go up to 400 or even 500. As the dose goes high, the necrosis rate is really high. And at 400 or 500 gray, we can achieve 100% tumor necrosis. So the techniques are multi-compartment or single compartment that I will explain you in the few next slides. So we normally use personalized dosimetry these days. So these are 5 scenarios we come across and where we can offer the radioembolization. This is radiation segmentectomy. If the tumor is in one segment, we can burn the whole segment actually. And this will give the similar results like we do the resection of the tumor. We can burn the whole lobe This is radiation lobectomy, actually. So if the residual liver is sufficient, we can burn the whole lobe, actually, depending upon what the tumor size is. And this is multi-segment. So here we can offer like 2 doses, and we can offer double segmentectomy. And this is the multifocal unilobar disease without macrovascular invasion. The third is bilobar disease, but it's still without macrovascular invasion. Here we still can offer multi-compartment. And the third, or the last, fifth scenario is where there is angio invasion. Keep in mind, radioembolization is really good in patients with segmental, subsegmental, and even if one side of the portal vein, like right or left portal vein, is involved. And if you can manage to inject the theraspheres in the arteries, those are supplying the tumor thrombus, they really do well. So TACE versus TARE is, there is a few things. Like TACE has embolic effect, we block the arteries, we can do multiple sessions. This syndrome is really high in TACE group, actually. But it has a limited role in where there is a portal vein thrombosis, and it has low cost. But TARE has a minimal embolic effect. So arteries are patent, you can go and do retreatment. It's often a single session because it's very expensive. The post-embolization syndrome or complication are very rare. Patients really tolerate very well. And in portal veins, it's better. It has a better response, but definitely the cost is higher. So what exactly with the TARE we can offer? We can offer curative treatment. We can do bridging to transplant, and we can offer palliative treatment. So yttrium shrinks the tumor to meet the transplant criteria. This is what exactly we do in downstaging. And in curative cases, we can achieve the 100% response, actually. So these are a few studies in terms of like what is the response rate with the TARE. So this is one of the study with the Lewandowski, who has reviewed, it's a retrospective thing. If we do TARE in a single lesion in this study, less than 5 or 5 centimeter, the overall survival rate was like 98%, 66%, and 57% in 1, 3, and 5 years. So it is better than surgical resection or comparable with surgical resection. Next is in the less than 3 centimeter lesions, if you compare the 1, 3, and 5 year response rate survival rate is 100%, 82%, and 75%, which is very encouraging. So TARE is not only for the big tumors, we can do even in smaller tumors. Then is the legacy study by Dr. Salim from US. He treated the tumor like from 2.7 centimeter to 8 centimeter, and again, it has 86% overall survival rate up to 3 years. And the patient was downstage for the resection or the liver transplant. And the dose here was used around up to 410 gray, which I was talking in the previous slides. So then is the dosisphere study, which actually explains what's the difference between personalized dosimetry and the standard dosimetry. So the personalized dosimetry definitely have survival benefit over here, 26 months versus 10.7 months. So it's now clear that we should go for the personalized dosimetry. So these are few cases which I will share. This was first case, 32 years, A6, 6 centimeter lesion, and we did, it has portal vein thrombosis, good performance status, and it was not a patient for transplant or resection. So if we look at, this is the lesion here, and this is the video, you can find the lesion here and the portal vein involvement. So we did actually the shunt study, and this is the point of injection we decide before, like in lung shunts, before the injection of theraspheres. This is the SPECT scan to see the lung shunts. These are the lungs there, and you can see how nicely the tumor is highlighted. And we know our dose is going into the tumor. So this is after treatment. We did PET CT, and this is the activity uptake. And that explains how nicely the activity is there in the area of tumor. You can see over here. This is all the like yttrium-90, and that's the residual liver on the other side. This is the bottom liver. And this is the post-treatment scan. We normally do after 3 months. It has gone very quickly. So these are the static images. If you look at the margins, it's nicely burned tumor, actually. And in the previous slide, there was no arterial enhancement. So this is how post-radioembolization the things appear. You can see how nicely and cleanly the tumor is burned out. The case 2 was a 72-year lady, again, large tumor, 7 centimeter, portal vein involvement. Our AFP and PIVCA2 was like 746 and 40. Her bilirubin was a bit high, and she was not a candidate for any other treatment apart from systemic. So her ECOG level was 1 and BMI 32, MELD, and it was B7. So we decided, after imaging, we decided to go ahead with the radioembolization. So you can see the tumor here and the portal vein involvement. Even in this case, there was a biliary involvement. So this is a video for the CT, and you can see the tumor over here and the portal vein involvement. I'll quickly go through. We went into MDT, and the decision was TACE plus immunotherapy or chemotherapy. We did angiogram, and this is how we do normally angiogram. And that's the cone beam CT. Actually, we can do on angiography to see the exact location of the tumor and vascular supply. We injected the TheraSpheres, and this is post-injection. You can see how nicely it is highlighted. This was the initial scan in like 4 weeks. You can see how nicely it's burned out, and you can see the vessels are still there. Again, same video for the CT. You can this is how the tumor is gone. So there was no enhancement, no residual tumor. This is static images, and she had a scan after like 3 months, and it was gone. So the tear we did in this case, tear and immunotherapy, because of the biliary invasion, and her AFP came down to 15, and she is doing well even after like 10 months. Case 3 is another case. This patient has multiple tumors. So if we go through the CT, this is the tumor here, and then is a tumor at the bottom. I will show you in next images, like in segment 6. So this is how it appears on this is the one tumor, second one, and this one at the bottom. This one. And you can see at the imaging like angiography. So this is how we calculate, because we calculate the doses, like there are three feeders in this tumor, so we have to order 3 doses here. Like this, the one, second one on this side, and third one at the bottom. So we did like TheraSphere injection, and this is the post-TheraSphere injection PET CT. We are still waiting for the response, and I think it's a good response. TACE can also be good if it's done like really nicely. And the only thing in the TACE one should keep in mind is the devascularization of the tumor. Whatever the material you are using, it doesn't matter. You're using like conventional TACE, DEB TACE, LUMI TACE, there are so many things, or you're just using the particles. The only thing is the devascularization. As much as you will hunt out the vascular supply, the tumor will go down. So there are few cases. This was the patient actually with a huge big 9.7 into 6.4 centimeter lesion with portal vein involvement. And this is how it appears after the couple of TACEs. So it has a complete response. Again, 16 centimeter tumor, good supply, like single or two supplies. We did TACE, and the response was like 100%. You can say complete response, but we will discuss later. And this is, again, another tumor, and the response was really good. So nicely done. TACE also do good, but I think the TACE still has the upper edge. So take-home message is, the intermediate stage HCC is a heterogeneous liver cancer. Management is shifting from a single thing to multimodality, personalized treatment. We should always discuss these cases in a specialized MDT to have the plan for the treatment. And TARE is taking now as a curative as well as the downstage, the tumor to bring down for the liver transplant. It is improving the overall survival. It has less toxicity, and we can cure the tumors. Thank you very much. Actually, there is a definition by Japanese society that's called the refractory TACE. If the consecutive 3 TACEs doesn't work, means either the tumor is stable or it is progressing, you should stop doing TACE, or you should think of opting for other options. But whatever you are doing, it's not working. So 3 TACEs is the from our side, we normally go like that. If it's not working, we should think of other options, like we can do RFA, we can think of radioembolization, or there is an issue because if we don't have we should go and review the things, because if it is not responding, we are not targeting the vessels properly, actually.
Quick question. It's almost like doing a surgical septicectomy. So do you look into the FLR, or is that relevant, or is that not relevant?
Of course, when you're treating with the big tumors, we have to calculate the liver volume. What exactly is more or less similar as we do resection. In cirrhotic patient, we need to have a 40% residual volume. And in normal liver, if we have a residual volume of 30%, that's fine. But we still keep it up to 40%. If you have a 40% liver back and the patient is child A, we do like segmentectomy or lobectomy or this kind of stuff.
Dr. Ramzan, the imaging-wise, TARE gives a beautiful image, but in terms of overall survival benefit, does it have any benefit in long-term the tumor recurrence time or overall survival as compared to TACE, as compared to immunotherapy? In your final comments, you said that it is effective, it offers curative therapy. What is your long-term data? How come, have you ever seen anybody getting cured? Did you take any patient to the liver transplant time in your own series? Personally, I've dealt with about 14 cases. None of the cases survived to the time of liver transplantation. Overall survival as compared to TACE was not any different.
Actually, अगर आप देखें ना तो जो डाटा अभी टेर का है ना, that's not really into the market, because you know that in 2025 this was approved in EASL guideline, and NHS has opted this thing. in 2022, because we are normally what exactly we are doing, even at PKLI, we are doing palliative tear actually because of the cost, because the government is not funding the curative tear. So still we have the data we have in the literature is more or less of the past actually, and that's of palliative tear. But there are certain like legacy study and the other studies. The overall, if you go with the explant, like where the tumor was downstage with the radioembolization, as compared to TACE, where we have given the 400 like gray of the dose, the tumor necrosis was 100%. And keep in mind, we like reviewed our data at PKLI of the explant, where we say that the TACE has complete response. The only tumor, 100% tumor necrosis is around 20%. That's why the TACE is not that effective, even if it's a radiological 100% response. If you bring the thing out, it is still, the tumor is there. But yes, there is still way to comment that the tear is how much curative, how much long-term survival is. So we have to come up with data, because whatever the data is, it's still saying there's not much difference between two. But I think in the future, because the West has gone to the curative tear, and they are doing even 3-centimeter lesions, and many centers, TACE is replaced by the tear in West actually. I think in a couple of years you will have the answer. But at this moment I don't have.
With this context also, I would like to add that nowadays curative tear is called now TAR ablation, because we are going towards ablation. So transarterial radioablation.
Yeah.
How does it compare with SBRT?
SBRT, actually SBRT, RFA, microwave cryoablations, resection, they have more or less similar like outcomes, and they can target only 3-centimeter tumors. Anything bigger than 3 centimeter, if you do, the results are not really good. But keep in mind, SBRT has come up with a really good results in smaller tumor. But when you go above the 3 centimeter, all these, the recurrence and residual tumor, with all these, you can say the modality is high. So we are normally using SBRT in patients where there's a partial response to the TACE, or there is a partial, we have a like 3-centimeter residual tumor, and those patients are really doing good. We have like 3 or 4 patients, and in like data, just SBRT is good for up to 3 centimeter, but the things go down above this level. For the tear, yeah. $5.1 million in PKLI. There is a program. We have like 26 doses approved. Up till now, we have done 12 radioembolization cases. 50% were supported by the hospital and 50% were paid actually. So, but keep in mind, we are supporting only tumor more than 8 centimeters. Less than 8 centimeter, we don't have the option to go for, because if we will go for that, we will be burn our budget actually. So what exactly we are supporting, that is a palliative tear, not the curative actually. So if someone wants to go for curative, he has to pay. We can't because that is, the company is sitting behind. We are talking to the Boston Scientific, because this is another, I think that's a very good question in a way, because I went to Turkey and they are doing 3,000 to 4,000 tears a year actually. And the dose cost is around $3,000 to $4,000, I think. But we are getting in $14,000 the dose actually. There are a couple of things, like there are 30% taxes, then vendor is involved. We are talking to the Boston Scientific to reduce the overall cost, but still because the number is so low, they're not yet convinced. But I think if we increase the number, we will definitely have, like, the cost will go down. Thank you very much.